Integrated Health Care Delivery Systems by Emedi Babele. Table of content, which I'll go through very quickly. The definition and description of an integrated healthcare delivery system, the government and administrative structure of an IDS, the components of an IDS, hospital-physician alignment in an IDS, stages of physician integration, financial aspects and operation of an IDS, the integration of clinical care, the impact on costs, quality and access to care, the focus on population health, the overall impact on consumers, insurers and providers of an IDS, an example and description of an operating integrated delivery system, the example of Cleveland Clinic, followed by a slide on Cleveland Clinic by the numbers, where I actually list some stats and facts about Cleveland Clinic, and Cleveland Clinic Community Benefit Report. And the final slide is a slide of references. Definition and description of an integrated healthcare delivery system, IDS. There are various definitions. Here I kept 3 definitions. The first definition is by Inthoven, 2009. The healthcare network connects providers across economic, non-economic, and clinical domains to provide a coordinated vertical continuum of services to a specific patient population or community. It is accountable for clinical and physical outcomes and has systems in place to manage and improve them. Second definition from Lega 2007, a delivery system which provides or aims to provide a coordinated continuum of services to a defined population and are willing to be held clinically and physically accountable for the outcomes and the health status of the population served. The third definition that I chose was from Moore and Coddington, 2008. An organization which uses corporate structure, strategic alliances, governance, management approaches, culture, financial practices, clinical information systems, and other tools to facilitate and issue delivery of this type of care. Governance and administrative structure of an IDS. There are many governance and administrative principles. These are kind of structural aspects in many articles. They actually call them principles or aspects, and sometimes there's kind of a the term components and principles actually used sometimes interchangeably. So here, I mean, they say that it's actually there are many governance and administrative principles. 10 among them, 10 are frequently and consistently presented. This one is from OLK et al. 2015. 1. Comprehensive services across the care continuum. 2. Patient focus. 3. Broad geographic coverage and rostering. 4. Standardized care delivery through interprofessional teams. 5. Performance management. 6. Information systems. 7. Organizational culture and leadership. 8. Physician integration. 9. Governance structure. And 10. Financial management. Next slide. Components of an IDS. Following components or aspects of an IDS have been identified. This is from Conway et al. 2013. 1. Legal governance. 2. Finance. 3. Infrastructure and capacity building, and within which we see administrative infrastructure, workforce development, measuring and improving performance. 4. Assignment to a healthcare delivery model. 5. Patient-centered medical home, PCMH. 6. PCMH access. 8. Specialty diagnostic services. 9. Hospital inpatient care. And 10. Support for special populations. This list is not exhaustive. but those are some of the main or key components of an IDS. Hospital/physician alignment in an IDS. So incentives for vertical integration in the healthcare industry have led many hospitals to consolidate into health systems and profess a desire for closer alignment with affiliated physicians. Some models of physician integration are listed here. Accountable Care Organization, ECHO, Clinically Integrated Network, CIN, Patient-Centered Medical Home, PCMH, that we saw earlier, Quality Collaborative, QC, Call Coverage, Clinical Co-Management Service Line, Equity Model or Captive Group Model, Foundation Model, Independent Practice Association, IPA, Joint Venture, Management Services Organization, MSO, Medical Directorship, Physician Hospital Organization, PHO, Physician Recruitment, Professional Services Agreement, PSA. And then in this slide, I kind of, found this diagram that kind of, sorts the different stages of physician integration. This one was obtained from Satiani back in 2010. Stages of integration. And as we move from left to right, we basically, moving towards lesser level of integration to greater level of integration. From physician as customer to partner to employee to leader and or to governing partner. And from left, there's the first circle where physician is actually an arm's length customer, and this could be found in an MSO, in a PHO, in gain sharing, and other examples are given below. And in the second circle, it can be a part-time partner. You find that as an example in joint ventures. And then the next phase, actually, there's a blurring line of separation, as a faculty practice model, fully employed versus owned PCP networks. And then the final one where there's a greater integration in governing as a governing partner. You find this in clinical foundation model, in staff model, in an HMO. Financial aspects and operation of an IDS. Yeah. The Accountable Care Act payment reform presents uncertain future for safety net providers. Therefore, some innovative providers use value-based payment models, which require increased accountability for quality, health outcomes, and costs. Progress along the reimbursement continuum is crucial, for savings and risk reduction. An integrated healthcare delivery system, IDS, involves, coordinated collaboration among providers, which results in focusing on improving care, health, and cost effectiveness. Now, in contrast, the existing, which is the most dominant, system, or fee for service system, encourages patient retention, costly therapies, personal objectives over patient care, as practitioners are paid, individually by patients and insurers. And I found an example here from Conway et al. 2013 of a graph that kind of demonstrates the value-based payment model, which basically correlates higher financial risk with higher accountability. So as the it in the line in the graph, they shows the continuum of risk-based contracting. So as there's more risk, there's also high accountability on the side of the hospital or the physician. And if there is less risk, corresponds with less accountability. I thought that's really an interesting model, the value-based payment model. Next slide, operational aspects of an IDS. An IDS moves, care to lower cost settings. So it reduces the costs. It's supposed to reduce the cost of care by improving access to primary care for patients, by reducing unnecessary emergency department visits. It links the care continuum, by connecting the various aspects of it, by increasing physician collaboration across care settings, by increasing compliance with order sets and care guidelines. And it limits the cost of supplies by increasing the use of generic drugs and reducing the use of advanced imaging studies. So there's supposed to be some kind of reduction in costs, which has not really been proven. However, that is really some of the intended, objectives of integrated systems. Integration of clinical care. Through partnership, hospitals and physicians may focus on quality improvement and efficiency. Evidence-based integrated care is better served by physician network. Joint efforts and adequate resources can concentrate on specific situations. Comprehensive data networks improve the evaluation, monitoring, and management of service utilization. Impact of cost, quality, and access to care. Integrated delivery systems have been shown to have a positive impact on cost, quality, and access to care. Quality by enhancing coordination of many sorts of providers across a larger network. Costs by enhancing efficiency by streamlining operations and removing unnecessary expenditures. Access by allowing for greater options in terms of provider location and the acquisition of extra resources as needed. Focus on population health. National policies are promoting integrated health and social care models to improve population health and reduce costs, requiring validated social risk measures, increased organizational engagement and flexibility from policymakers. IDS enhances public health by improving care quality, lowering costs, and expanding access. This strategy goes beyond typical biomedical paradigms, emphasizing cross-sector collaboration. Primary care and public health collaborations can address local health issues and enhance outcomes. The empirical literature emphasizes treatments aimed at disadvantaged high-risk populations in order to address care inequities. Impact on consumers, insurers, and providers. Consumers, vertical network integration provides patient care coordination, customer satisfaction, and treatment effectiveness. Administrative costs are reduced by limiting paperwork and utilizing shared staff. Digital tools in integrated delivery systems enable clinicians and patients to communicate more quickly, allowing for virtual medical advice. Insurers profit from cost savings, which can be passed on to clients in the form of lower rates and better coverage. They are more qualified to identify preventive measures, cutting rates as a result. Providers, physicians can save time by minimizing administrative work, gaining access to more data, enhancing diagnostic and treatment design, and staying up to date on developing trends and current evidence in their profession. Example of and description of an operating IDS. An example of Cleveland Clinic, mission, vision, and values of Cleveland Clinic. In a summary, at Cleveland Clinic, we work to provide compassionate, highest quality care in a setting of education and research. Cleveland Clinic is a renowned integrated delivery system, a non-profit academic medical center that offers comprehensive healthcare services. Its patient-centered approach emphasizes collaboration between healthcare providers, patients, and their families. The clinic is known for its innovative approach, including the use of electronic health records, EHRs, and telemedicine. Cleveland Clinic has established affiliations with other healthcare providers to expand its reach and provide better care to patients. Cleveland Clinic by the number. Here, I listed some facts and stats and numbers on Cleveland Clinic. Patient visits. In 2022, there were 12.8 million outpatient encounters, 303,000 hospital admissions and observations, and 270,000 surgeries and procedures throughout Cleveland Clinic's health system. Location: Cleveland Clinic is a 6,665 bed health system that includes a 173-acre main campus near downtown Cleveland, 22 hospitals, more than 275 outpatient facilities, including location in Northeast Ohio, Southeast Florida, Las Vegas, Nevada, Toronto, Canada, Abu Dhabi, UAE, and London, England. Employees. Among Cleveland Clinic's 77,000 employees worldwide are more than 5,658 salaried physicians and researchers and 19,000 registered nurses and advanced practice providers, representing 140 medical specialties and subspecialties. Research and education. Cleveland Clinic has 2,063 residents and fellows in training and 110 accredited training programs with research funding totaling $402 million. Community. Cleveland Clinic serves the community by providing uncompensated health care to those in need, engaging in a broad range of medical research, education, and training programs, and supporting community health initiatives. In 2019, the community benefit contribution totaled $1.3 billion. And here's a map of Cleveland Clinic's community benefit report in 2020. We see they allocated $185.8 million to financial assistance, $547 million to Medicaid shortfall, $34.4 million to subsidized health services, $130 million to community health, $312.3 million to education, and $101.9 million to research. So the impact on community and on research and education and for job creation, it's just massive. And this is the final slide, which is the list of references that were used in this presentation. Thank you very much.